Welcome to the inaugural episode of Nutricrinology Classroom, your online source for PowerPoint presentations given by me in front of a webcam. The first topic that I will be lecturing on is cholesterol, specifically LDL cholesterol, as a direct agent in heart disease, which is a topic that has been floating around recently. And I just so happen to have, I wrote down notes about this presentation. This is a former student presentation I gave in 2013 for a seminar course in graduate school. It is in 3 parts. This first part states the lipid hypothesis of heart disease and the diet heart hypothesis. It lays out predictions for observations if those hypotheses are correct, and then presents a sample of studies whose observations challenge those hypotheses. This is not a literature review of the entire field, which would be more or less impossible if you know anything about the size of the cholesterol and heart disease fields. This is an overview and a challenge to the cholesterol heart disease question, which, as a positive statement, does not have to fail to predict results in all or even most data sets, but in my opinion is untenable if even several carefully selected data sets reveal results contrary to its principles. So what I'm forwarding here is that the idea that cholesterol causes heart disease, and perhaps even also the additional idea that consuming cholesterol gives you serum cholesterol, which then causes heart disease, is a very difficult hypothesis to defend in the face of all of the data that we could bring to bear on the question. And I'm just using some of it here. And this is the first part of a 3-part series, as I said, where I'll be talking about basically the mainstream conception of what these different hypotheses are and how easy sort of it is to challenge them with just a few data sets. To start off, so perhaps you're not even aware of the diet heart hypothesis or the lipid hypothesis of heart disease. This is probably what most people think of about cholesterol and heart disease. And I suppose they were communicated this general idea from the medical community, doctors, very simplified ways of communication. Clearly, this isn't what anybody is seriously forwarding as how cholesterol actually works. But unfortunately, a lot of people think this is how it works, which is that arteries are like pipes and they kind of get stuff stuck on the inside of them that makes their diameter smaller, sort of like how if you wash too many fats down your sink. And in the case of your sink, it'll eventually cause your sink to back up. In the case of your arteries, it'll eventually cause your blood to not flow properly and then perhaps cause something like a heart attack. The lipid hypothesis itself, it's a little fast and loose. It's just the proposition that there is a causal link between cholesterol, specifically LDL cholesterol, and heart disease. And this is the model, a very, very broad, not specific model of how that would happen, which is that LDL molecules, which are low-density lipoproteins, complex with a lot of cholesterol and some triglyceride, they sort of get out of the lumen of the vessels and get into the tissue part of vessels, past the intima, past the first line of endothelial cells, and they're treated as a kind of a foreign invader by leukocytes, mostly macrophages, and gobbled up. If this happens too much, so if there's too many of them and they're getting consumed too much by macrophages, it'll cause those macrophages to die in a process called apoptosis. And when those macrophages die, they'll just stay there in the blood vessel near the inside of the vessel, but just embedded within it, and build up over time. And they'll build up calcium and cause calcification, and they'll build up a kind of proteinaceous, what's called a fibrous cap. It's kind of like collagen, sort of like a scar. And this is what is called an atheroma or an atherosclerotic plaque. And over time, as in the pipe, this will build up and partially occlude the artery, increasing blood pressure. And in sort of the worst case scenario, sometimes the pressure gets so high, or the change in pressure, depending on which vessel it is, will eventually cause this atheroma, the fibrous cap, to rupture. And if it's big enough, it'll travel down the vessels, and the vessels sometimes, when they drain into tissues, they taper off to a very small diameter, they could be blocked. And if it's something like, say, an artery that feeds the heart, and that gets blocked, that's a heart attack, because now your heart is not receiving oxygenated blood. The diet-heart hypothesis, on the other hand, is the proposition of a causal link between dietary cholesterol. It was first conceived of as dietary cholesterol, and then later on saturated fat and cholesterol. Really, most of the evidence exists for saturated fat and the presence of serum cholesterol. And this is a cartoon model of how that would work. Pretty simple. You consume something that has cholesterol in it. It gets digested, absorbed across the enterocytes, and put into the serum. And so there's your direct link right there. It just goes from the digestive tract into the blood. So if these two hypotheses are true, which is that LDL cholesterol causes heart disease and dietary cholesterol consumption causes a high serum cholesterol or a high LDL cholesterol, then you would expect the following observations: that you could predict serum cholesterol levels by cholesterol intake. That is to say, if you had two groups and one consumed more cholesterol, they should have higher serum cholesterol. And that should be redundant across data sets. All data sets, really. Unless there's like a compelling medical reason why some groups behave differently. Furthermore, you should be able to predict heart disease with serum cholesterol levels, which is to say, if you have two groups or maybe a bunch of groups, and there's one that has a lot of serum LDL and one that has much less, the group that has much more should have more heart disease, whether you're measuring outcomes like a heart attack itself or a stroke, or if you're measuring occlusion, the progression of atherosclerosis. All of those things are considered heart disease. It's like a big tent. And so that's kind of the forward-looking prediction based on serum cholesterol. And then there's the medical side of it, a medical prediction, which is if you lower cholesterol pharmacologically, you should expect to improve cardiac outcomes, so less cardiovascular disease, depending on how you're measuring it, than a group that, say, is not given a cholesterol-lowering intervention. Jumping right into it, I will be pulling first from data from the Framingham heart study, which it may be the largest medical study of all time. It's definitely the largest in terms of heart disease. It's something that was started in the 1940s and continues to this day. You can check it out in the URL at the bottom of this slide. I made this presentation in 2013, and by then they had a little bit more than 15,000 participants, maybe way more than that by now. And the Framingham heart study itself, it's not like one study the way you would think of as a study that's published in a paper. It's an ongoing collection of data that people mine from this data and do their own studies, because it's a big questionnaire of diet and lifestyle and then medical outcomes of the people in this study, mostly around heart disease. So you could ask a bunch of different questions, smoking, consumption of cholesterol, taking cholesterol-lowering drugs, all kinds of things, and what happens to these people a year later, 5 years later, 10 years later, 30 years later. It's been, the first cohort, if there's anybody still alive, it's like 80 years. So this is a sample of some of the studies, titles of papers that have been published from data from the Framingham heart study, and highlighted in blue, cholesterol and lipids and the risk of coronary artery disease. just a few statements from this specific publication, the Canadian Journal of Cardiology in 1988. It was a coronary heart disease screening campaign looking at all different kinds of factors and then coronary heart disease over 35 years. So this is quite a bit of data, which you would want for a study like this. And the end result is it suggests factors other than total or low density lipoprotein cholesterol must be considered when evaluating coronary artery disease. And this is when they brought in the HDL thing. So I just wanted to point out that the cholesterol heart disease hypothesis, it started off very basic. It started off, if there's cholesterol in your blood, it will cause atherosclerosis, which causes heart disease, or which is heart disease. Then it became LDL cholesterol. Then it became LDL to HDL, like a ratio. And then it moved on to small, dense LDL versus big, it keeps getting complex. And the reason why they're doing this is not really because they're discovering new physiological explanations through experiment for how this stuff works, although that's a small part of it. It's really mostly an attempt to explain why the previous version of the hypothesis fails to predict outcomes in so many studies. For example, looking at the diet heart hypothesis from the Framingham heart study, eggs are, something that a lot of people eat. It's a normal food that's consumed in America. It has been for a really long time, very high in cholesterol. So one of the ways to look at cholesterol consumption is egg consumption. It's very closely related. That's where most people get their cholesterol from. In this particular data set, people were broken up into three groups. A low, which is 0 to 2 eggs per week. So people that eat very little eggs, little cholesterol intake. Medium, 2 to 7 eggs per week, and then high is anything more than 1 egg per day, 7 to 14 per week. And pretty easy to see in the charts here that in both the male and the female cohorts, there's no statistically significant difference between the low, medium, and high groups. They're all basically centered around a mean value of a little bit over 200 milligrams per deciliter of serum cholesterol. And if you really look closely, which again, none of this is statistically significant, but there is a trend that actually the low egg consuming group has a higher mean in the males, and the high group, has a lower mean in the females. You can kind of look around, but none of that really matters. Basically, it's unrelated, which they wrote up in their paper. There's no indication of a relationship between dietary cholesterol and serum cholesterol. They further go on to use some statistical methods to tease out cholesterol from other factors. So, for example, holding animal fat constant, there is still no relation of cholesterol intake to serum cholesterol. And then further, if they do a multiple regression, so looking at both animal fat and dietary cholesterol either separate or together, there is also little suggestion of an association between this pair of variables and serum cholesterol. Now, of course, there are data sets that show a relationship and data sets that don't. My position is that means you don't really have anything. How is this communicated to the public? Well, the director of the Framingham Heart Study, William B. Cannell, who is probably not the director anymore, I don't know. This is a long time ago. Although there is no discernible relationship between reported diet intake and serum cholesterol levels in the Framingham Diet Study group, quote, it is incorrect to interpret this finding to mean that diet has no connection with blood cholesterol, unquote. Which I guess is true as far as it goes, but what's he really saying there and why? And if they did find a discernible relationship, would he go, well, this doesn't mean, probably not. He would probably just let that stand. The second data set I will be pulling from is from a Japanese cohort, a publication from 1993, Changes in Total Serum Cholesterol and Other Risk Factors for Cardiovascular Disease in Japan, 1980 to 1989, so the 1980s. As everyone probably knows, Japan historically we're talking, pre-World War II and into antiquity, had quite a different diet than Europe and Western Europe, Northern Europe. Those places, they didn't consume dairy, so they weren't consuming butter. They consumed just less animal foods in general, more fish, less land animal, and so cholesterol, things with cholesterol. And then after being conquered in World War II, their diet was partially westernized, and they have had changes in what are considered cardiovascular disease risk factors. This is actually a case of the diet-heart hypothesis basically proving true, for this group in this time period. So hypercholesterolemia, so like beyond normal, like medically high cholesterol, increased in all groups, all age groups, during the decade of the 1980s in Japan. And not only were there more instances of hypercholesterolemia, but the regular average cholesterol level increased for both men and women during the same time period. And their calories from fat increased by 3%, not a super big deal, but still, if the diet-heart hypothesis and the lipid hypothesis were correct, that's a cardiovascular disease risk factor. Now, what were the cardiovascular disease outcomes? And these are all direct quotes from this paper. Mortality from heart disease, and in particular, coronary heart disease, declined. Increase in serum cholesterol levels in the Japanese population, contrary to downward trends in mortality from heart disease. The life expectancy now this is not just from the 80s, but from 1965 to 1990, in both men and women in Japan increased by about 8 years. Which means, of course, that total mortality must have went down, and about half of the decrease in total mortality during the decade of the 1980s was attributable to less cardiovascular disease mortality. In other words, more or less the exact opposite you would expect from a population that had higher cholesterol than before, higher LDL than before, etc. Next data set, cholesterol and heart disease in ages 70 and over. This paper is called Lack of Association Between Cholesterol and Coronary Heart Disease Mortality and Morbidity and All-Cause Mortality in Persons Older than 70 Years. Published in 1994 in the Journal of the American Medical Association. The reason why I chose this paper is because heart disease is the leading cause of morbidity in this group. That is to say that if you are over 70 and you're sick, you're most likely sick with heart disease. Furthermore, if you have a myocardial infarction, a heart attack, you are 25% more likely to die from it than people below 60. So why is that important? Well, if you're concerned about heart disease and you want to find things like what causes it, how to prevent it, really any disease, where would you look? A group that has the highest incidence of that disease or the lowest incidence of that disease? The highest, right? Because that's where your low-hanging fruit is. That's where the bulk of the cases are going to be. This is a cohort of about 1,000 people from New Haven, Connecticut. Their serum cholesterol was measured, and 4 years later, they had a follow-up of cardiovascular disease rates. And wouldn't you know it, there was no significant association between serum cholesterol and myocardial infarction or unstable angina, which is just not getting enough blood to the heart. It causes pain in the chest. So a heart attack and then sort of something that might lead to a heart attack or just your heart not working so well. In fact, not only was there not an association, but there was like an inverse trend that the highest rates of those diseases were in the lowest serum cholesterol group. They were broken up into tertiles, so thirds. So the people who had the lowest third of serum cholesterol had the highest rates of heart attack and heart pain. And the difference was about 59%. That is to say, the odds ratio for those two, for myocardial infarction and unstable angina, between the highest and lowest serum cholesterol groups was 0.59. So if you were in the highest serum cholesterol group, you only had 59% of the likelihood of having a heart attack or heart pain from low blood flow to the heart as compared to somebody in the lowest serum cholesterol group. So almost just slightly more than half of the chance. And this is a visual representation of survival curves. So of course, sad to say, but in a cohort of people over 70 years old that goes for 4 years, the study goes for 4 years, people are going to die, a not insignificant number, and some of them are going to die of heart disease, a heart attack or something like that. And you can see, I forget, I clipped this so many years ago. I don't know if the left side is males and the right side is females or the other way, but you can see the right graph has the lowest serum cholesterol group, which is the solid black line, has the lowest survival over all 4 years consistently. And then the black dotted line is the highest serum cholesterol group and spends all of its time in the highest survival range. In the left chart, it crosses over a little bit, although the survivability is overall better for the highest cholesterol group and worse for the lowest. Last data set. Now we're going to ask the medical question. Intervention, pharmacological intervention, standard versus intensive lipid-lowering treatment. A study called Effect of Intensive versus Standard Lipid-Lowering Treatment with Atorvastatin on the Progression of Calcified Coronary Atherosclerosis over 12 months. A multi-center randomized double-blind trial. So all the bells and whistles of a study like this that you would want to see. In the journal Circulation, published in 2006. So, like it says in the title, this was a randomized, multi-center, double-blind trial of about 500 patients with moderate atherosclerosis. And this atherosclerosis is measured by something called, what they're measuring is coronary artery calcification, which is one way to measure atherosclerosis. And you can do it non-invasively, as opposed to probing for actual plaques. And the treatment or the study design is that half of these people will be given a low dose of atorvastatin, which is just one of the many statins on the market to lower serum cholesterol. The other group will be given a high dose for a year. This is just the baseline traits of both groups, showing that they're basically the same, age, everything else. So the study design itself, both groups, there's a run-in period where both groups receive the low 10 milligram dose of atorvastatin for 1 month. I forget why that was in the study, maybe to make sure that none of them had an acute negative effect from statins, and if they did, they would be taken out of the study. After that 1 month lead-in, they were randomly split into two, where one half it continues to get the low dose, and then the other half gets the 80 milligrams, which is 8 times the dose, for 1 year. And then they would be given this measurement of their coronary artery calcification before and after this. The way that they measure it is something called electron beam computed tomography. They picked coronary artery calcification because it can be measured this way, which is non-invasive. You don't have to get in and look at arteries. It can be done with X-rays. It's fairly low radiation, and there's a bunch of things in atherosclerotic plaques, and one of them is calcium. There's also the proteinaceous matrix, and those things all increase proportionately as an atheroma grows. So consistently, if you have an atherosclerotic plaque that's progressing in size and continuing to occlude the artery more and more, you will be able to see with radiation, within radiation imaging, that there's more calcium there as well, because there's always going to be calcium in the atheroma. Of course, it's a risk factor for myocardial infarction, basically is heart disease. And a normal progression rate of anything from a quarter to a half more of growth every year has been reported for cardiac patients. So that's sort of a normal progression. And previous studies have showed a link between LDL lowering statin treatment and the progression of coronary artery calcification. The outcomes on cholesterol are as expected. The 10 milligram atorvastatin group actually didn't lower their cholesterol at all, their LDL, and the 80 milligram group lowered it by about 20 milligrams per deciliter. And in both groups, C-reactive protein was lowered, a greater trend in the 80 milligram group. That's kind of interesting. If you know how statins work, they don't just lower cholesterol. They attack a step in cholesterol synthesis that there's a lot of things that statins actually do because it doesn't simply address cholesterol. That can actually be maybe good, definitely anti-inflammatory, which is why it affects C-reactive protein. Not to say that statins are good, but it's a complicated. The effects that the drug have on your body are multifaceted, and that's something we're going to get into in the later series of presentations. So what about the outcomes on coronary artery calcification? Well, the progression was virtually identical. Furthermore, the adverse event occurrence was similar. So things like heart attacks. The mean progression of CAC scores were 25 and 27% in the 10 and 80 milligram groups respectively. So a small, insignificant, trend that actually there was more coronary artery calcification growth in the higher dose, lower LDL present group than in the other group. And here I just list a couple of other studies. So when I was making this presentation, I just wanted to make it totally clear that I picked, for example, with the medical intervention study, I picked what I picked because it had really easy to explain data. There are other trials that show that atorvastatin specifically and other statins do work, whether you're measuring coronary artery calcification, some other method of measuring atherosclerosis progression, or adverse heart disease events. And then there's studies that don't. So a lot of these studies have really cheesy acronyms. I don't remember what they stand for, but they'll try to make it snappy. Reversal, prove it, TNT. Those trials showed positive results with a statin in, slowing the progression of heart disease over time, whereas the Bell's trial, the St. Francis Heart Study, and of course the study that I just reported from did not. No difference in coronary artery calcification progression from intensive lipid-lowering treatment. And I point out that the St. Francis Heart Study was 4.3 years follow-up. I believe I noted that because it was by far the longest. Like the study I just reported was 1 year, so 4.3, that's in things like this, the longer they go, the better. So just those data sets alone, those observations really present a challenge. Of course, there's a million studies, and people could go back and forth and say, well, if LDL doesn't cause heart disease, then why in this study does reducing LDL reduce the risk of heart disease in the people that are given this treatment? And it's not always happening, but it happens sometimes. It seems related, yada, yada. Well, what that usually means is that there's some third factor that's affecting LDL cholesterol and it's affecting heart disease, or it's affecting one that then affects the other. There's some kind of relationship, but it's not, the direct LDL cholesterol to heart disease relationship that's being presented. And this alternative hypothesis that better explains both the diet, heart, and lipid hypotheses, what they fail to explain is something that I will be developing and presenting in the second and third episodes of this lecture series, I guess. So I hope that you enjoyed this one and that you join me for the next. And this last slide, in case you didn't catch them before, are the URL for the Framingham Heart Study that you can go to and look at all of their data sets and everything about them. And then the information of the 4 publications that I drew data from. That's all. Peace out.